This is Mrs. Hall, and this is the first lesson in our treatment unit, the last unit of AP Psych. We have come a long way. I'm really proud of you guys, and I'm sorry that we have to rush through the things here in this treatment unit, but we do need to get a test taken this week, and I know that it's the week after spring break, so we do need to work pretty quickly as we go through this stuff, but it's really nice because it's actually a review. Back to the things in Unit 1, and you'll see what I'm talking about in just a few minutes. I want to start with some introduction and some definitions to some things in treatment. A person needs to seek treatment for some sort of a psychological disorder or some sort of a daily stressor when this disorder is causing problems in the person's everyday functioning, meaning that it's affecting them on a day-to-day basis, it's causing them distress, it is dysfunctional in terms of its patterns of behavior, and the person is unable at this point to do anything to help him or herself. Two types of treatment that we have in terms of the location. We can have inpatient care, which would be 24-hour care in some sort of a hospital setting. That could be Pine Rest, that could be Hackley. They have a psychiatry department, a psych wing, I guess I should say. But more commonly, we see more outpatient types of treatment taking place where a person goes into a counselor's office and has an hour-long session, maybe once a week, maybe multiple times a week, maybe bi-weekly. That's all determined by the therapist and the counselor himself. The term psychotherapy is a broad term that we use for any approach to treatment. Really, we're going to see when we say psychotherapy, we're talking about the psychodynamic perspective, but people have taken that term to make it mean just a generic term for any kind of professional treatment. Some terms that mental health professionals are given, they can be called therapists, clinicians, providers, and then the person being treated can be referred to as a client or a patient. Difference between a psychiatrist and a psychologist, hopefully you know this by now, but just a real quick review. A psychiatrist is a person who has a medical degree in psychiatry. They can write prescriptions, and they can also work with people who have mental illnesses, whether it's a severe mental illness or a less severe day-to-day stressor type of a problem. A psychologist, we've looked at those different degrees that we can get in psychology. These are going to be counseling or clinical psychologists who have some sort of a graduate degree or maybe even a postgraduate degree in that specific field. A master's degree, a PhD. The newer one that's out now, it's been out for probably 20, 30 years, is called the PsyD, Doctorate in Psychology, as opposed to the PhD, which is a doctorate in philosophy. The minimum that a person needs to work with clients one-on-one would be a master's degree. There are some other ways that we can work with people who have mental illnesses, and that would be clinical social workers, and their main goal is to try to get their clients back into the regular working world, the regular community that they are from. They tend to work in hospitals and things, and their goal, like I said, is to get their clients back out living at home and living on their own. Psychiatric nurses work with psychiatrists or clinical psychologists, mostly psychiatrists, in that inpatient treatment facility, wherever that might be, and they don't do any of the diagnosis or anything, but they work one-on-one, hand-in-hand with the psychiatrist. And then a counselor. This is the counseling psychologist that we've talked about. I've mentioned they need a minimum of a master's degree. They can work in colleges, in their counseling centers. They can work at human service agencies and youth centers. They can have their own private practice. There's lots of opportunities for counseling psychologists. Some of the areas of specialty that counselors work with, marriage counselors, family counselors. Some specialize with adolescent issues, stressors that adolescents in particular go through. There are some that deal specifically with eating disorders. There are child counselors, child therapists, lots of different areas that a person can go into in counseling psychology. Some of the history of treatment, kind of sad. The earliest treatments that we used to have would just simply be do nothing for the person with the mental illness. We wouldn't care for them at all, and we would be embarrassed by them, and so we would hide them away. Sometimes we would disown them and send them out to just try to provide for themselves, and in extreme cases we would send them away to a facility to just simply house people who had abnormal behaviors. At the beginning, we used to think that mental illness was equivalent with demon possession, and I believe that in the last unit I expressed to you some of the different ways that people would try to get rid of these demons. They would use trephination, drilling a hole into the person's head to try to release the demon. They would feed them these terrible brews and concoctions, trying to get them to vomit out the mental illness or the demon himself. And then I also mentioned bloodletting. When we look back at Hippocrates' humors and trying to balance those four humors, we would do things to reduce the amount of various humors in that person's body. I know I've got a big span here from 1300 to 1900, but really it was a progression from that time before we started to see more humane treatment of the mentally ill. We used to imprison them and just lock them up, and we didn't have any specific treatment techniques because we didn't understand what was going on. We didn't have the technology to be able to look into the brain and see that there could be something actually biological going on. I wanted to share with you this term bedlam, and I'm pretty sure this is one of your AP vocab terms in your English class, but Bedlam refers to an old asylum, and it was called the Priory of St. Mary of Bethlehem. It was in London, and it's what we consider to be the oldest mental hospital, if you want to term it a hospital, but it was more of a tourist attraction. And it was a place where we would take people who had abnormal behaviors, usually they were violent, and we would chain them up in these dungeons in this castle, and people would buy tickets to come and watch the crazy people do whatever it is they do when they're all locked up and crazy. And they wouldn't do anything to really help them. They just confined them there so they weren't bothering anyone else. So the term bedlam, which hopefully you know means chaos, it comes from the people would shorten that term Bethlehem, and they called it bedlam. And that's where we get that term for chaos, because it refers back to the chaos that took place in that mental asylum. In the mid-1500s, these asylums were popping up more and more places throughout Europe, and as I mentioned before, they were just kind of a housing place for people who were mentally ill or who had some sort of abnormal behavior. And you can see some of the things here that I've already mentioned in terms of ways that they would try to handle these people and try to fix them, if you will. We get into mental health reform beginning with Philippe Pinel, and he was a French man who went into the asylums, and there was one in Paris in particular, and I'm sorry, but it's I don't have it off the top of my head, but he went in and encouraged the leaders of this asylum to give him a chance. Let's take them out of their chains, let's talk to them, let's use more humane treatment methods, let's unlock them and let them walk around, let's let them have some freedom, let's treat them like human beings more humanely and converse with them and see what happens. And as a result, he saw much calmer patients who were more easy to manage simply because they were cared for. Kind of back to our kindness projects. Some other reformers, Dorothea Dix was the first United States reformer in the area of mental illness. She worked in state-funded hospitals and pretty much followed Pinel's work in terms of freeing patients from the prisons that they were in here in the United States. Josef Breuer was the first person to use hypnosis to get patients to talk about their problems. And we've talked about what hypnosis is, and this would obviously be a psychodynamic therapeutic technique. In the early 1900s, we still had harsh treatments. They were still pretty violent. We used electroconvulsive shock treatment or therapy. The people, from what I understand, were not necessarily sedated, and if they were, it wasn't very much. We would just shock their brain, hoping to change the chemical makeup of the brain. But the most violent and the harshest treatment that we've ever done is called a prefrontal lobotomy. And that is where, it's pretty gross, but we would go in with a utensil similar to an ice pick, and we would just kind of stir up the frontal lobe or the prefrontal cortex of the brain, and interestingly, we wound up with much calmer patients. Well, duh, because we just took away all of their ability to think and plan and make decisions and things like that, so they were pretty much just vegetables that didn't do very much. They could walk and they could do whatever, but they couldn't think for themselves anymore. We no longer do prefrontal lobotomies, just so everyone's aware. We found over time that the asylums that we had, the mental health institutions or the hospitals, they were not reaching their potential. They weren't doing what they were intended to do. So we started closing a lot of these in the 1950s. And then as more medications came on the market and we started looking more at community-based treatments, meaning that the goal was to get people back into their everyday life, living on their own, or at least living at home with someone else who could help take care of them. We didn't want to just institutionalize them. We began to be able to get rid of these state institutions, and we call that deinstitutionalization. We're trying to get people back living life in a normal manner and not just locking them up. We do find even today, though, that many of our seriously mentally ill clients, people who can't afford adequate health care, things like that, we do find a number of them to be homeless. And we've talked about the correlation, that it's not a cause and effect, but that it's just a link. It's something that we see, that many homeless people also have a mental illness, and vice versa. The treatments that we work on today, they emphasize prevention of mental illnesses, and there's a huge push with healthcare with preventative care. And so what we do is we look at this primary prevention, which is trying to reduce the causes of disorders. We look at people who aren't holding jobs, people who don't have homes, things like that, things that we know can be linked to things like depression and anxiety and other mental illnesses, even schizophrenia. And so we are working to help these people to prevent that mental illness from even occurring by helping them to find jobs, helping them to find homes and things like that, so that we don't have to experience mental illness. Secondary prevention would be working with people who are at risk, those who have experienced some sort of a serious traumatic event, and trying to help them prevent the mental illness from even occurring. And then finally, tertiary prevention. This is when we have people who are already suffering from mental illness, and we're trying to prevent those from becoming more severe by working with them in a counseling setting or in a hospital setting. We have 3 different types of therapies and treatments that we're going to be looking at this week. And the first is composed of 3 different types. They're called insight therapies, and we'll talk about what that means. But we're looking at psychoanalysis, client-centered therapy, and cognitive therapy. Psychoanalysis would obviously be Freudian, Adlerian therapy. Client-centered is going to be Carl Rogers and his humanistic therapy. We've talked a little bit about that. And cognitive therapy, we're going to focus on Albert Ellis and Aaron Beck's cognitive therapy for depression especially. We also have behavior therapies, Skinnerian therapies, and Bandura, and we'll see some others, Julian Rotter and things. And then the biomedical therapies. These are going to be all the medications that we have on the market. And this is where it all comes full circle, like I mentioned. If you remember, I said that we're going to go right back to Unit 1 again, and we've got these perspectives in psychology. I don't have written down here the biopsychosocial, but you can probably see where that would fit in here. And then we also don't have a sociocultural or an evolutionary treatment for mental illnesses, just because they don't quite fit in the ways that these do. So that's our introduction to the treatment unit and the history of treatment. And if you have any questions, as always, make sure you just ask. See you soon.